Good morning, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The P&A is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The P&A is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar is presented by Dr. Richard Byrne. Dr. Richard Byrne joined the Mayo Clinic of Florida in April of 2024 and serves as the department chair for the Department of Neurological Surgery in Florida. We greatly appreciate you coming out and presenting for us today. Please hold, as there will be a brief delay while we change presenters.
Okay. Can everyone hear me? Can somebody hear me?
We can hear you. Thank you.
Okay, good. All right, and you can see my screen?
Yes, everything looks
Good.
great.
All right, well, it's a pleasure to be here with you. I'm going to be talking about pituitary adenoma surgery. Part of what I want to talk about is the really big ones, the more difficult ones. We'll talk about those later. But I'm going to go over surgery for pituitary adenoma. The primary audience is patients, caregivers, folks who are relatively new to this. So if you're looking for a lot of high-end surgical video, you're probably going to have to watch my next presentation sometime, but we won't be doing that here today. We will show a couple of intraoperative pictures for anybody that's not comfortable with that. I'll give you a little warning and you can look away for those. But primarily, we're going to be talking about pituitary adenoma surgery. And we will get to this topic of the giant pituitary adenomas, which we just sent a paper on. There's a lot of different kinds of brain tumors. Pituitary adenoma is one of the most common one. Typically, we call it a brain tumor. It's taken care of by brain surgeons, but in reality, it's not in the brain. It's underneath the brain, at the base of the brain. So when we think about it, it's down here, if you can see my arrow, down here at the base of the brain, underneath the brain, down near the sinus cavities. And you're looking at a couple of different kinds of pituitary adenomas here of different sizes and shapes. And let me just get this out of the way. There are other things that can look like pituitary adenomas in this area. There's meningiomas and craniopharyngiomas, cysts, and other sorts of more troubling kinds of tumors. But most of the things that we see in this area are going to be pituitary adenoma. So to get us oriented, this is what it looks like when you look right down the midline of the brain, from the nose to the back of the head, with the nose being more towards the left, the back of the head being more towards the right. If you can see my arrow, all of this up here is brain. The pituitary gland, if you follow my arrow, is down here at the base of the brain, connects up via a structure called the infundibulum to an area of the brain called the hypothalamus. The hypothalamus listens to the body, the glands from the body, the blood, etc., and then tells the pituitary gland what to do to bring us to what we call homeostasis. In other words, normal temperature, normal water balance, normal energy levels, etc. Now, it just so happens this is a really busy place at the base of the brain. The carotid arteries are right next to it. The optic nerves are just above it. Basilar arteries just behind. There's other nerves here that move the eyeball and so on, and a lot of important arteries. So it's a really, really busy place at the base of the skull, and that's where pituitary tumors can be difficult to deal with from a surgical standpoint, because there's just so many things going on around the pituitary tumor. So typically, pituitary adenomas are benign tumors of the pituitary gland. Benign means it's not going to spread throughout your body, but benign doesn't mean friendly. benign tumors, if they get big enough and involve critical structures, can cause trouble. They can cause particularly visual loss, or they can cause double vision, or hormone dysfunction, either too much hormone or not enough hormone. We categorize pituitary adenomas by their size and whether or not they're secreting hormones. So it might secrete growth hormone or cortisol or thyroid. They're often found incidentally. So in my practice, when I was in Chicago up until recently, I'd see over 100 new patients a year with a pituitary adenoma, but I only had to operate on a fraction of those folks. Oftentimes they were found incidentally. Someone gets into a car accident or has a headache or something, and then there's a small tumor in the pituitary gland. Most of those people don't need to have surgery. They need to be followed up with MRI scans. They need to have their hormone levels checked. And as long as it's not causing any problems, we do follow-up MRI scans. Some of these tumors will just sit there and do nothing for many years. And then some will grow and some might cause trouble, and that's when we talk about surgery. So these are some routine tests that are done in patients who have pituitary adenomas. Because the tumor is right below the the optic nerves, a tumor might press on the optic nerves. So we'll test patients' vision. We'll look at their visual fields, like how much of the visual field around you can see, the acuity, how well do you see, and then we'll check hormones, prolactin, thyroid hormones, some of the sex hormones, growth hormone, hormones that have to do with energy level and growth, so ACTH, IGF-1, and cortisol. There is one sort of tumor, a prolactinoma, that it can be treated with medication. I'll show you the results of that. We like to treat those with medication if we can, but sometimes patients will present with what looks like a tumor, but it's just a big swollen gland. So patients with hypothyroidism and pregnant patients can just look like they have a big swollen gland. It can look like a pituitary tumor, but it's not. And these tumors that we see that are an incidental finding, in other words, they seem to be not causing any problems. We looked for one reason, someone was dizzy, and then we got an MRI scan, and then we see there's a small pituitary tumor. Some people call that an incidental oma. So this is a pretty typical looking pituitary adenoma. If you look at my arrow, it's right here at the base of the skull. It's pushing up on the optic nerves. It's pushing up into the brain somewhat. So a person like this might present with visual loss or some problems with their energy level, because if you look here, we don't really see the pituitary gland very well. It's probably pressed up on the side. They might have hormone deficiencies, or they might be secreting a hormone that's causing symptoms. So typically when someone presents with something like this, it might be because they have some visual loss. So we'll take a look at their vision. We'll check all of their hormones. We'll have them seen by an endocrinologist, and then we'll make a decision about whether surgery is appropriate. Typically, if somebody is losing vision and has a tumor like this that we can't treat with medication, this would be a typical case that would come to the operating room for surgery. Most of the time when we operate on these patients, we end up going with general anesthesia. It takes roughly 3 hours. It's usually a team of an ear, nose, and throat physician that puts in an endoscope. If you look at my arrow here, coming in through the nose with the patient asleep, through this dark space here called the sphenoid sinus. So we call this transsphenoidal surgery. The ear, nose, and throat doctor gets us here. The neurosurgeon opens up this area called the sella, which is where the pituitary gland and subsequently the pituitary tumor lies. Then we open up a very thin layer called the dura, and then we take tumor out. There's going to be some intraoperative pictures later as an example. So we'll take that tumor out, and then the optic nerves will be decompressed. The pituitary gland will be decompressed. And in doing so, we do run some risks. in any operation, there's general risks of any operation: bleeding, infection, and anesthesia. Specific risks here, the optic nerves could be injured. It's just very unlikely. The carotid arteries, which are right next to the tumor, could be injured, which could cause stroke. That is very, very unlikely. I've never seen that in my 27 years of doing these tumors. Or this dark stuff back here, this is brain fluid, cerebrospinal fluid. So as the tumor is coming down, sometimes that fluid can leak out. Just seeing that little bit of fluid during surgery is not a big deal. We're really good at patching that and stopping any further leakage. But if it persists after surgery, sometimes we have to put a tube in the low back to divert the fluid, or come back up surgically repairing any leak here. So these are some things that can come up with surgery, and patients typically are in the hospital maybe about 3 days on average, and then getting home. So one of the risks that's a rare risk of having a pituitary adenoma is the risk that the pituitary adenoma may bleed. This right here is an example of that, where the tumor bleeds and causes sudden visual loss and other symptoms. That's a thing called pituitary apoplexy. That's a very rare event. It happens about 1% of patients will have a presentation like this, where their tumor presents with bleeding and sudden loss of vision. So it's not something to worry a lot about. It's just one more bit of calculation about a 1% per year risk that the tumor may bleed. And then on the happier note, sometimes we'll run into a tumor, a very large tumor like this. You can see it here. That can be treated with medication. This is the one that can be treated with medication successfully. In many cases, sometimes it can't be treated with medication because the medications may have side effects. The patient may not tolerate the medication. But if they do tolerate the medication, this would be a prolactinoma, a tumor that secretes prolactin. And prolactin levels being in the hundreds or thousands would indicate a prolactinoma. And you see a very large tumor like this, it's a very formidable looking problem. But then we put them on medication if it's a prolactinoma, and we might get a result like this, where the tumor just shrinks away and the patient is significantly better afterwards. Now, pituitary adenoma surgery has a long history. It's over 100-year-old history. So up in the upper left here, we see a fellow named Harvey Cushing operating here. Here he is looking down through a patient's face, operating on a tumor. You can see the light bulb on his forehead, and you see the audience back here. This fellow right here in the white, it's a guy named Eric Oldberg. Eric Oldberg started the neurosurgery program at Rush, where I was for 25 years as an attending neurosurgeon. So Eric Oldberg learned that and did a lot of transphenoidal surgery in Chicago. And this is what a surgical team looks like now. There's no more of this sort of primitive looking stuff. We use high definition endoscopes. There's a team of ENT physicians, ear, nose, and throat physicians, and neurosurgeons having a look up into the base of the skull without having to make any openings. There are times when we have to do a transcranial approach to a pituitary adenoma. We'll go over that a little bit later on. Sometimes the right thing to do with a pituitary adenoma is to radiate it. And that's sometimes the case before surgery, sometimes the case after surgery. If you look in the bottom left, you'll see what a radiosurgery machine will look like. This is just one type. There's about 5 different types. You'll hear about the Gamma Knife and CyberKnife and Trilogy and X-Beam and TrueBeam. They're all radiation machines. It's essentially focused radiation aiming right at the tumor. And that's pretty successful in getting the tumors to slow down or maybe shrink back some. The doses used for radiation are somewhat limited because the most sensitive part of the brain to radiation is the optic nerve, and the optic nerve is never far away from a pituitary adenoma. So we have to really limit sometimes the amount of radiation we give, and that can limit the effectiveness of radiation in pituitary adenoma surgery. And then over on the bottom right, this is intraoperative imaging. Sometimes we use intraoperative imaging, ultrasound, intraoperative CT, or intraoperative MRI scan when we're operating on pituitary adenomas. So one of the revolutions that really came about 20 years ago was skull-base endoscopy. So it allows us to use these lighted scopes to look at the base of the skull. In the past, when I started my career, we would have to make an incision either in the nose or in the mouth and then get back up through the sinuses and use a microscope. This allows us to use an endoscope, which is a camera with a light on it, and allows us to get a very, very close look at the tumor without having to make major incisions. It's just easier for patients to recover from this sort of surgery. And I started my career doing the microscopic approach, and then in 2006 switched over to the endoscope, and I do think it is easier on patients to recover. We wrote a paper down here in the bottom right, looking at what is the learning curve when someone picks up the endoscopic intranasal approach. And it does take a while before surgeons become familiar with it, and it just becomes easier for them to do and safer to do. So advances like endoscopy and a better understanding of the variability at the base of the skull. There's a lot of anatomic variability in the bone structure at the base of the skull that can be tricky during surgery. These advances, along with others like understanding where the optic nerves tend to cross, the optic chiasm, and how that affects our choice of surgical corridor, all of these things make the operations safer and more effective. And then as far as recovering from surgery, we're still working through a variety of paradigms on how to repair the hole at the base of the skull after surgery. And there's a lot of different ways to do it. And it's much more important if there's intraoperative cerebrospinal fluid leak, because again, we just don't want that fluid to continue to leak out, and it can lead to infection, meningitis, if it isn't repaired after surgery. So let's take a look at a case. This would be what I'd consider a fairly large pituitary adenoma. I think you can see it here this is a coronal plane looking. So if you take a look at the arrow, here's the right side, here's the left side, here's the midline, and there's the tumor right there. And we can take a look at what are the surgical challenges here. We'll also look at it from the midline cut right here. We can see that it involves the carotid arteries to the side. You can see those circles off to the side. It involves an area called the cavernous sinus, where some nerves that move the eyeball and give sensation to the face run through that space. And then the optic nerves are pushed way up here. So this is somebody who's going to have visual loss. And the tumor may or may not be stuck to those optic nerves way up here. There are other nerves back here that move the eyeball, the carotid arteries here again. And then that cerebrospinal fluid, if you take a look at my arrow here to the right, is always there around the tumor and may or may not leak out during surgery. And then there may be some other arteries, the basilar artery, the anterior cerebral artery, that may be stuck to the tumor capsule as it's coming down. So during surgery, these are things that the surgeon is always thinking about. We're always thinking about safety first. We want to make everything go away. We want to cure everything, but there's always a trade-off, safety versus how much we get out. So these are things that are running through the surgeon's mind during surgery. Yeah, so there's going to be a couple of pictures here. If you don't want to see these pictures, I've got 5 pictures here for intraoperative pictures. For those of you that like that, you're welcome to watch these. So why is it that we choose often to come through the nose? Well, it's just a straight shot corridor that allows us to get into tumor without having to tangle with all of the important structures above the tumor. So here's that intraoperative picture. This is what it looks like if we come from above. So if you take a look at my arrow, this is the temporal lobe over here, the frontal lobe is over here. We're looking from the right side. Here's the base of the skull. The pituitary gland lies here. This is the connection to the hypothalamus called the infundibulum. Here is the right optic nerve. Here's the carotid artery. And the brainstem is right back here. The left optic nerve is over here. So there's a lot going on here. And there's a lot of important structures that we would have to dodge if we come in this direction. There are some cases where we absolutely have to come in this direction, but I think you can see in this image why we might choose this corridor rather than this corridor. So that's something that the neurosurgeon has to think through. Here's what it looks like coming in with the endoscope coming from below. This may look just like a lot of bone and mucosa to you, but this is where the tumor is. Here is the right optic nerve. Here's the left optic nerve. The carotid artery on the left, carotid artery on the right, the base of the skull up here. So we get in through the sphenoid sinus. Remember, this is called transsphenoidal. We're in the sphenoid sinus here. We open this very thin bone. Here's a layer of what we call dura, separating the tumor from the sinuses. We open that up nice and wide, and then we open up and start delivering tumors. So that's what it looks like as we're getting in. This is what it looks like once we've opened up that dura. There's the dura reflected back. We're inside what we call the sella. Here is tumor within the sella. We're using a suction and a curette. So we're gently persuading some of the tumor out. Thankfully, most of these tumors are relatively soft. The really firm ones can be more difficult to deal with, but the soft ones we can usually persuade out without too much difficulty. And then we'll send a biopsy to confirm that it's a pituitary adenoma, but most of it just ends up going up the suction. And then we go from the bottom, then we go to the sides, we go to the back, and then we go for that part that's higher up near the optic nerves, which are up here, those important arteries that are up here, and all of the brain fluid is way up here. So we'll go to do that last. And here it is. You can see some of the tumor here coming out. You'll see some blood here. The reason for that is these tumors are fairly vascular. And of course, the brain is very, very vascular too. So we'll always see some blood during surgery, and that's okay. And this is what it looks like at the end. The tumor's been cleared out. There's some hemostatic agent here in the sella where the tumor used to be. The residual gland is back here. You can see this gland had been very, very much compressed. So there's not a whole lot of gland left. So this person almost certainly already needed hormone replacement therapy and will likely need hormone replacement therapy going forward. This is that final layer that separates the sellar space, the sella being where the pituitary gland and the tumor were, from the brain space. So if we open this layer, we would see brain fluid and we would see the optic nerves up here and we would see brain. So that's what it looks like at the end. And we see that this has all come down and we've emptied that whole area of tumor. So when we think about the goals of surgery, because we can't see cells, we can't know that we're at the level of a cellular cure. We're really good at making lumps go away, but trying to see cells during surgery is like trying to see ants from an airplane. It's not even close to being possible. But thankfully, most pituitary adenomas are not secreting hormones, and therefore they don't necessarily have to be cured. You can take all visible tumor out, and if there's some residual cells, you might see some tumor growth over 5, 10, 20 years. In my prior institution, where I was attending there for over 25 years, I would see patients back, and you might see a little bit of growth over time. And typically those patients, we would either do focused radiation or we would just watch them as long as they weren't causing any trouble. For the difficult ones that cause hormone secretion, we have to be more aggressive because it's really the hormones oftentimes that are causing the trouble and not the tumor mass itself. So in those cases, we sometimes opt for early return to surgery, or we might opt for medical, try to achieve medical control, or we might do focused radiation. If a tumor is really large, in this case, if you take a look here, You can see some of it's at the base of the skull, but some of it is very high up into the brain. If we can't get all of that to come down, let's say we can only get half of that to come down via transsphenoidal, sometimes we have to come back and go transcranial. And that can either be done with a minimally invasive approach, or sometimes we have to do a bigger opening to get underneath the brain and take care of that last part of the tumor. And then there's always this trade-off of the perfect patient versus the perfect postoperative MRI scan. Ideally, we'll have both, but in big cases where tumor is really stuck to the optic nerves or important arteries, we tend to prefer the perfect patient, or as perfect as possible, rather than the perfect post-op MRI scan. And because these are typically benign tumors, we'll follow those any residuals over many years, and again, might consider focused radiation or medical therapy. So this is really just a summary of when we'll go through the nose, when we'll go through the head. Bottom line is, through the head, it's typically for larger tumors that are wrapped up in important structures that we can't see through the nose, sometimes for recurrent disease, and sometimes if the tumor really creates a nice corridor for us. And we can even do that with a minimally invasive approach, just incision over the eyebrow and then coming in right above the orbit. Just to demystify the focused radiation treatment options, this is what a focused radiation machine looks like. This is the Gamma Knife machine. The Gamma Knife is not actually new technology. This was invented in the 1950s by a fellow named Lars Leksell in Sweden. Of course, there's been many upgrades and updates to the Gamma Knife technology since then. Right now, it's almost all automated software that does all of the dose planning. But this requires a few hours in the hospital. It's an outpatient procedure. Again, because pituitary tumors are typically very close to the optic nerve, focused radiation has its limitations, because as much as we want to treat the tumor with radiation, we don't want to hurt the optic nerves. So if the tumor is too close to the optic nerves, it really limits the dosing that we can use with focused radiation. That's why a lot of the times you'll see that we don't often start with radiosurgery. That's something that we'll do only if surgery has been proven to not be able to get rid of the rest of the tumor, and then we'll consider focused radiation. So now let's talk about giant pituitary tumors, just to wrap things up. This is a project that we put together with some of my former residents, and when I was up in Chicago. And we had a large experience with the giant pituitary adenomas, and this is just a subset of that large experience. These are some of the most challenging cases there are in neurosurgery. Some of the smaller tumors that we see of pituitary adenomas are not technically very challenging, but these giant ones really are, and they're about as hard as it gets in neurosurgery. So let's take a look at some of these things. These are some of the things that we need to think about are: how big is it? What is it invading? What structures is it involving? Where is it going? Is it going just up the midline? Is it going off to the side? What's happening with the hormone situation? Is it secreting hormones? Has it caused hormone lack of secretion? And then there's all sorts of, it's a difficult thing to recover from postoperatively, because as you can see, tumors this extensive will require a lot of surgery, and there's a lot of postoperative healing that needs to go on. In cases like this, the one on the left here, despite being so large, is one that we might try to get rid of entirely through the nose. Sometimes we'll have to take down a little bit of the skull base, like we did in this case, take down a little bit of the skull base through the nose, and then take care of this part of the tumor, and then reach up and go after the residual portion of the tumor up here that's pushing up into the brain. In cases like this on the right, when it really goes off the midline, we're really limited in what we can reach through the nose off the midline. So a case like this, we're almost certainly going to have to stage, with part of it taken out through the nose, some of it taken out transcranial by coming up from above. And then you'll see that there's also this other problem of this dark fluid space up above, if you follow my arrow, that's a process called hydrocephalus. Hydrocephalus is just Latin for water in the brain. So there's always normally water in the brain, but this is too much. And the reason is the tumor has blocked off the normal fluid flow for water in the brain. And this person has that excess water, and that has to be dealt with as well. So that makes it even more challenging. So when we think about how to approach, we think about, well, going through the nose, the endoscopic transsphenoidal approach. And then there are other ones coming from the front, coming from the side, coming from the top even. And oftentimes we'll have to stage these. And oftentimes it'll be 2 operations same day, or it might be 2 operations the same week. Sometimes we'll let patients recover for a few weeks and then bring them back. Every case is a little bit different, and these are things that we work out with the patient based on some safety indicators. So when we're looking at these really, really big ones, we think about, well, what gives us the best view of the tumor? So we look along the long axis of the tumor. So if it looks like it's going straight up, we tend to go from below because that gives us a view straight up along the long axis of the tumor. If it's going off to the side, then we tend to think about, well, maybe we need to take a different approach to this. And then some tumors will seem to have just one compartment, some will have multiple compartments. That comes into our decision making as well. And then again, is it going straight up or is it going off to the side? And then there are some indicators on the MRI scan about whether or not the tumor is going to be firm or soft. Naturally, we prefer soft tumors that are highly suckable and that we can persuade out without having to cause any disruption around it. The really firm ones can be much more difficult to deal with. And then is there neurovascular invasion? In other words, is it wrapped up on any important nerves at the base of the skull, particularly the ones to the eye for vision or moving the eye, or is it wrapped up around an important artery that's going to the brain? And then finally, what is the surgeon's experience? That really does matter too. What does the surgeon feel comfortable with in their experience? And then some of it has to do with the anatomy. Not everyone's skull base is the same. Some will have extra bone. If you follow my arrow here, some will have extra bone before we even get to the sella where the pituitary tumor is. Some will have small air spaces in front, and some will have very large air spaces in front. Generally, it's a lot easier to get through an air space than it is to drill through bone. So when we see these big open air spaces at the base of the skull, that favors an approach from below. So these are just some of the things that your surgeon is thinking about when they're thinking about different kinds of surgical approaches. And then there's even things like how close are the carotid arteries to the tumor? So there's a phenomena called kissing carotids where the carotid arteries might be very, very, very medial towards the midline and might be very close to the tumor. When there's other cases where the carotid arteries are pushed out laterally, and that helps us with our surgical corridor. So in this series, and this is really over about the last decade, these are 46 giant pituitary adenomas that I'd operated on. And of course, there were many more before that, but this is just the last decade. And in 25 of those, we went exclusively transsphenoidal. By the way, when I'm saying giant, what I'm talking about is 4 centimeters or greater. So 4 centimeters is a pretty good sized tumor at the base of the skull. It's anything greater than 1 centimeter and it'll be pressing on the optic nerves. Anything greater than 2 centimeters, it'll be pressing on major arteries and so on. So once you get to 4 centimeters, it'll be involved in all sorts of things. So these are the really, really tough ones. So about 25 of the 46, we got done just straight through a transsphenoidal approach up through the nose. And then there are other ones where we had to do from a transcranial approach exclusively. And then in 15 there at the bottom, we went from below and then came from above as well. So we had to do 2 different operations, 2 different stages. And that's okay. When you're talking about what can be a life-threatening problem, 2 different operations to keep it as safe and effective as possible is okay. Some patients can have complications from this very, very complicated surgery, as you might imagine. Cerebrospinal fluid leak, stroke is possible, hydrocephalus, and then we have a decision at the very end, how much needs to stay behind. If a tumor is really, really stuck to something important, it might have to stay behind, at least in part. Here's some published case series for giant pituitary adenomas in the last decade. You'll see there's only 4 of them from the United States, a series this large. There are some experiences in Asia that are very large, like in Turkey and China and Japan, but thankfully, most pituitary adenomas are not this big. So we'll take a look at a couple of individual cases. Here's one here in the upper left, where you see a tumor here through the base of the skull that's pushing up into the brain space. You see that there's that extra fluid here, hydrocephalus, but thankfully there's a corridor coming in through the nose that allows us to get in here. And if we need to, we can come back from above, or we can even go through the ventricle to take out some of that tumor. This one over here to the right, you can see most of that can come out in a transnasal approach because it's in the midline. That little bit over here, we'll either have to come back for it, or we can leave a little residual because it's stuck to an important artery. And then down here in the bottom right, you can see this is invading a space called the cavernous sinus. The cavernous sinus is an important area that has the carotid artery and some important nerves that move the eye. That portion, if we can get it, if we can persuade it to come out on its own, we will take that out. But we tend to, some of that might have to stay. And then over here in the bottom left, you can see a very, very large tumor that's invading all sorts of important structures. For that, we're going to have to just do a subtotal resection. In other words, take out everything that we can as safely as we can, but there's going to be a portion there that we're simply not going to be able to take out. And here's just a few more case examples, and then we'll wrap up. Here's a very large tumor, obviously causing that hydrocephalus problem here. It goes off to the side, and it involves some very important arteries. So the majority of this tumor is going to be in the is in the cranial space. It's not at the base of the skull. So coming through here would really limit our view off to the side with all these important arteries. So I opted to come transcranial, which we did here. You can see all that tumor out through there. There's a little bit of residual at the base of the skull, but that is that's something that we can follow over time. This was the part of the tumor that was causing all of the trouble. Here's another one where you can see most of it is in the midline, and then there's this part off to the side. I was able to get to that too. But there's a portion here again in the cavernous sinus that I'm not able to cure because it's already too far away, and we don't want to risk giving the patient a stroke with the carotid artery there. So you can see that there's a little bit of residual with this tumor, but the majority of it is out. I had to take down portion of the skull base here in order to get to the tumor. And here's an example of one where it was mostly in the midline, and we had to take most of the tumor out, and then later that day came back transcranial and took out the rest of it from above. So these are just some examples of the toughest of the pituitary adenoma surgeries. I hope this has been instructive for you, and I'm happy to entertain any questions. Thank you.
Thank you, Dr. Byrne, for such a valuable presentation. We do have a few questions, and I will read one at a time to you. The first question is, what is a suprasellar extension?
So back here, let's take a look. I hope you can see my arrow. So the sella is down here. It's below the skull base itself. Suprasellar extension means above that. So all of this sort of Mickey Mouse ear portion, these lobes up here are suprasellar, up above, and that involves all of those important arteries and nerves. So that would be the suprasellar portion of the tumor. Thankfully, a lot of patients don't have much of that, so that's not something to worry about unless that's in an individual's case. And then the what we call the intracavernous portion, the cavernous sinus, is that portion that has the carotid artery and those important nerves that move the eyeball. That's this part right here. So if you take a look, here's the carotid artery. This is going to be the intracavernous portion of the tumor, and that's also more risky in taking that out. So you can see we opted to leave a portion of the tumor in the cavernous sinus rather than risking stroke and other problems.
Okay, thank you. And the next question is, are there any concerns for women who want to have children when it comes to treatment via radiation and/or medicine?
Yes, there are. That's, I think, the best question for an endocrinologist and your gynecologist. But the answer is yes. The pituitary gland is also responsible for secreting FSH and LH. These are hormones that are involved in pregnancy and maintaining regular periods. So yes, those. Having a pituitary adenoma can affect pregnancy. Having treatment for a pituitary adenoma can affect pregnancy, whether it's radiation or surgery.
Okay, thank you. The next question is, at what size does the tumor shift from micro to macro?
Well, it's typically defined at 1 centimeter. And a 1 centimeter tumor compared to what we're looking at here is not that big. I think we showed examples of tumors that would be about 1 centimeter, but these are much larger. So I wouldn't focus so much because it's an arbitrary decision made before I was born that one is going to be considered a macro and the other one's micro. Microadenomas can cause trouble too. They can cause trouble if they're secreting hormones. So when I think about pituitary tumor disease as a spectrum, I think about the biggest problems that we run into are the really big ones and the really, really small ones that are secreting hormones that are very difficult to see on an MRI scan and therefore very difficult to find during surgery. So those are the more difficult surgical problems that we run into. So micro doesn't necessarily mean good if it's secreting hormones. If it's secreting no hormones and it's very small, it's just something that we would follow with MRI scans.
Okay, thank you. Another question, do you suggest in a reoccurring giant pituitary adenoma that the patient use the same surgeon?
I guess it depends on experience. So the most experienced pituitary surgeons tend to attract these cases. So if you're seeing a very experienced pituitary surgeon who did their best with your giant pituitary adenoma, you're probably best following up with that person because they were in there. They know exactly what they saw. They know why they stopped, where they stopped, and that person would be a good person to follow up with. If the person who did the first operation is somebody that really does more spine surgery than tumor surgery, then you might strongly consider seeing somebody that does a lot of tumor surgery.
Okay, thank you. We have, what kind of side effects have you seen from giant pituitary adenoma pushing into the brain?
Yeah, I mean, cerebrospinal fluid leak, you can have stroke, you can have visual loss, double vision, seizures. There's a lot of things that can happen. Again, these are some of the most formidable tumors that a neurosurgeon will operate on in their career. So all of those risks are real risks.
Okay, thank you. We have a couple more coming up. I had a macroadenoma resected 18 years ago. It was a subtotal resection. It started growing toward the chiasm. I had conformal radiation with I had conformal radiation last year. If radiation does not control further growth, how complicated is surgery after radiation?
So radiation can be effective in slowing tumor growth down. Again, as I mentioned before, the limits of radiation are that the optic nerves are so sensitive to radiation, they always have to limit the dosing. The problem with radiation from a surgeon standpoint is it tends to make everything scar down. It tends to make things stick, tends to make things more firm. So as I was mentioning before, soft tumors are a lot easier to deal with than firm ones. And anything that's stuck to important arteries and nerves becomes more challenging to deal with higher risks.
Okay, thank you. Do tumors have to be macro to be considered for surgery?
No. In fact, like I was mentioning earlier, microadenomas that are secreting a hormone that is hurting somebody are entirely appropriate for surgery. If they are not secreting hormones and they're not causing visual loss or some other symptom, then typically that would not be surgery as a first choice.
Okay, 2 more questions. What can be the reason for the pituitary adenoma to grow back fast after surgery?
Primarily the intrinsic biology of the tumor itself. So some tumors grow faster than others. Some might take 2 decades to become large enough to require surgery. Some might take a year to become large enough for surgery. So each tumor is a little different from every other tumor that we see. So if a tumor comes back quickly after surgery, then we have to worry about, is this an atypical, more aggressive biology? And if it's more aggressive, well, then we tend to get aggressive with it too, and we tend to reoperate and then recommend radiation shortly thereafter.
Okay, thank you. And our final question is, what are some post-surgery precautions?
Well, right after surgery, patients might feel a little under the weather. They might feel a little weak. Some of that has to do with hormone shifting. Their cortisol might be a little low. Their thyroid level might be a little low. It takes a while to recover from the general anesthesia. So patients typically, we ask them to take it easy for a few weeks afterwards. No heavy lifting, no deep bending, because we don't want to cause cerebrospinal fluid leak. We do want to have follow-up with patients, particularly with their endocrinologist. Dr. Sampson here at Mayo, Florida is an excellent endocrinologist, and she keeps very close track of patients after surgery to make sure their sodium levels aren't dropping or their cortisol levels aren't off. We just need to make sure that the patients are getting back to a regular balance with their blood levels. There may be some discomfort in the nose. Sometimes we'll have packing in the nose, and that packing comes out a week or 2 after surgery with the ear, nose, and throat doctors. So just generally taking it easy, not doing any heavy exercise, and then making sure we have the medical follow-up.
Okay, great. Thank you so much. That is all we have for today. We really appreciate you, Dr. Byrne, and your presentation. It was a fascinating presentation.
Well, thank you all for your attention. I was glad to be with you.
Thank you.
Okay, take care.
You too. This concludes today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar, or if you'd like to share it with family members or friends, it will be available on our website at www.pituitary.org. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you for joining us, and enjoy the rest of your day.